start, I would like to acknowledge the traditional owners on the land in which I'm presenting on, or Donna's presenting on, which is Whadjuk Noongar Boodja. We would like to acknowledge elders past, present and emerging, and extend that welcome to all Aboriginal people that have joined us either in the room or online today. So, yeah, and I'd like to welcome Dr Donna Mak. So Donna has kindly is joining us today to really give us some more information on the update to the guidelines for chlamydia treatment. So you all may have received an email the week before last from CDCD in regards to this update. And I thought this was an opportunity to really hear from Donna, and also if you have any questions about that update that perhaps you're not clear about, or you may think of some questions by the end. So, so welcome, Donna.
Thank you very much, Veronica. And I would also like to acknowledge the traditional owners of the land on which I'm doing this. So this is the Whadjuk people of the Noongar Nation, and pay my respects to their elders past, present and emerging. So we sent out a update, and that was really just to get the Silver Book, which is our WA Health sort of source of truth for STIs and bloodborne viruses, in line with the Australasian Society for HIV Medicine, or ASHM, which publishes the national guidelines. And what we realised was that we did not have the updated treatment for anal, where are we? We didn't have the correct treatment for chlamydia. So probably what you've been doing up till now, you know, don't get all stressed, because the ZAP packs, which I know many of you in the endemic regions, you know, the Kimberley, the Pilbara and the Goldfields have been using, like that, that's still fine. And what it is that if you have a patient who has got chlamydia infection in their rectum, and I'm not quite sure how many of you would see people with chlamydia infection in their rectum, that we need to treat them not with just with the ZAP pack, but they need an extra dose of azithromycin after the ZAP pack. So I might just ask people who are with us, you know, how many of you would see patients with rectal chlamydia? Is this a common thing that you see, or not really?
No, I don't in Derby. Yeah.
Yeah. Okay. Others?
I don't think it's a common thing here in Kununurra at all.
Mm-hmm.
Brenda from the Goldfields. Sorry, I didn't say hello earlier. My camera was playing up. But yes, we don't also see much of it in the Goldfields, but whether we're testing that route is probably an answer there.
Oh, okay. Well, because that was going to be my next question to you. You know, so you know, most people have said no, we don't really see chlamydia infection in the rectum. So, but then you would only see it if you're testing for it. And is that conversation being had with the patients to find out, well, do you have sex in your bottom or in your bum? And if you do, then let's test for it, because it's not an uncommon infection in people who have anal sex. And if they do have anal sex and they have chlamydia infection in their rectum, most of the time it's not symptomatic, so you're not actually going to know unless you do the test. And I'm not just talking here about MSM, you know, women can also have anal sex as well. So, you know, it's potentially something that could affect everyone.
I just would like to welcome Alvin as well. He's from Derby Yarragon, and Joanne Moore from Derby there. So Alvin, I guess the question that Donna was asking was, is anal swabs like taken? People ask the question about anal sex as part of a routine screen at Derval at all, or?
No, it is not, and that's been evident since I've commenced working here. That the sexual health check, the default assessment that has been created by community care, does not even consider that any person would ever have anal sex. So it's mostly only targeted to vagina and penis. There's not even a default section for throat swabs. So how are we even going to do anal swabs? So this is something that you would think would prompt a review by those people who mostly use it. But even it's possible that there's over reliance on referring to a template that have been created and put in front of you rather than reviewing the needs of the community and asking those questions. So I reckon if we go to the default of a basic assessment, we're not going to ask those questions. So yes, it's not being asked here, it's not being assessed, and it's not being measured. So if we can't measure anything, how are we going to make some changes? It's great this discussion's being had. So if we learn anything from the update changes, it's certainly that we need to start swabbing, testing, detecting and treating as soon as possible to look at reducing infections and transmissions in the population. But that certainly would would take some leadership in designing an assessment tool. I believe, and us people involved in these sessions may need to lead the change and communicate with that, Communicare or those other software providers in co-designing a targeted assessment tool that meets our needs.
So in Roburn, they've answered that they don't really test there either. Yeah.
Right. So I guess I'm kind of just wondering then, rather than this being an update about that the treatment for rectal chlamydia is azithromycin 1 gram orally, and then you need to repeat the dose 12 to 24 hours later. Perhaps a more useful discussion to be had with the group of people here today is that how do we better offer testing for rectal infections, because we're certainly not going to be able to treat them if we don't know that they're present. And Alvin, what you said about the throat swabs is actually the other really important thing, because the other part of the update is treatment of gonorrhea in the throat. And if, as you say, people are not offering that testing to the clients, well, then we'll never need to treat gonorrhea of the throat because no one will know they have it, because it's equally asymptomatic in men and women. And we know that oral sex is, well, I mean, you know, these things are common. It's not like no one does them.
Yeah. And I look at it opportunistically, STI testing, you know, I think everybody's getting much better at it, but it's often not inclusive of anal swabs. And I know that there are some services that have become, you know, really clever about the way that they do offer testing, and sometimes it's showing them pictures like, you know, if you ever have sex like this. And it's not asking, are you having anal sex? But if you're having anal sex, then, you know, it's really important that we get the swabs from these areas, because the treatment is different. And we want to make sure we're treating you properly. And I know some services have, used stickers where they actually hand them the swabs and the person does it themselves. Obviously, the anal swab, they need to wet it down with either some saline or sterile water because that makes it more comfortable. And I know that we've got, I think it's Queensland have put out a chart that shows somebody how to do their tests. Like we've got that one from the WA Department of Health, but this one actually includes an anal swab as well. So you can,
But yeah, and in the Silver Book there is a picture of how to do your own anal swab, and where I work at the M Clinic, it was just routine. It's stuck on the back of the toilet door and everyone does it, and they don't really need lubrication or saline. They quite happily take the swab off and do it themselves.
Okay. Yeah.
The throat swab would need to be done by a practitioner. I don't think many people would. I wouldn't trust most people to do their own throat swab because it makes them gag. It's quite hard to do. But certainly anal swabs, yeah, you send them to the toilet, just like we've got that picture to teach women how to do their own self-obtained vaginal swab. The anal swab is, it's not hard.
Donna,
Yeah.
it's Jem here from SWAMS. So is it useful to do the MCNS anal swab as well, plus the PCR? Or
You don't
just do
need
the
to.
PCR?
No, if someone's asymptomatic, I would just do the PCR.
Yep.
If they've got symptoms, if they're saying they've got anal discharge or pain, then of course you would. But largely it's asymptomatic.
Yeah.
So the PCR and also from the throat, we see very few people with symptoms in their throat, but certainly at the M Clinic, I see plenty of people with positive swabs from their throat, even though they have no symptoms, and a PCR test is fine.
From the throat as well,
Yeah,
just a PCR test.
Yeah, just a PCR test. Yeah.
And also just another question, because it was changed to doxycycline being given for. How does it work with that?
Okay, so if you're in a region that is using doxycycline, so if you're not in the Kimberley, the Pilbara or the Goldfields, if you're in a region that's using doxycycline, then the treatment for chlamydia of the rectum is just the same. It's just your doxycycline 100 milligrams orally twice a day for 7 days.
Okay, thank you.
Yeah, so that's no change. The change was for the people who were in the context of the using the ZAP pack.
Okay, thank you.
Yeah.
In the Silver Book, Donna, it's got under specimen collection and handling. So if the patient has had receptive anal sex, oro-anal sex, ribbing or fingering and no anal symptoms, patients can be instructed how to take 2 blind anal rectal swabs himself or herself. So those 2 would be a PCR and a...
I think that's probably what it's saying, but really it is enough to do a PCR swab. Yeah. It really is enough to do a PCR swab. Yeah.
Yeah. Okay.
I will have a look at that and make the update.
Okay.
So then we might just move on to the other part of the update, which is treatment of pharyngeal gonorrhea. Now, again, this only applies to the regions that are using the ZAP pack, because if you're not in one of those regions, you would be treating, people with gonorrhea with ceftriaxone anyway. Oh, no, actually, no, you'd be treating with ceftriaxone and 1 gram of azithromycin. So actually, this does apply to everyone. So if they've got pharyngeal gonorrhea, they need to have ceftriaxone, the usual dose, which is 500 milligrams, and they need to have 2 grams of azithromycin orally, as opposed to just 1 gram of azithromycin orally. And that's just to bring it into line with what the Australian STI guidelines are recommending, because gonorrhea in the throat is, for some reason, I can't tell you the biology of it, but it's just harder to eradicate, so it needs more azithromycin. But again, I think if we're not testing people's throats, we're never going to have the need to treat anyone. And oral sex is very, very common, so we probably need to be doing a lot more testing of throats.
And Donna, that's just a single dose. You just give it as a single dose. Yeah.
Yeah.
Sarah, who is the sexual health nurse in Roebourne, has just commented a little bit earlier, actually. I think we need some good templates that enable non-sexual health nurses to ask these questions during assessments. And Matthew Bacon has said there are some services having a bit of success with opt-out anal swabs as well.
Yeah, I think that they're all, really good suggestions. And I would go so far as to say that, oral sex is so common, perhaps it should be opt-out throat swab too. If you're going to have opt-out anal swab, you may as well have opt-out throat swab. And
again, is most of those infections like that, asymptomatic?
Yeah. I mean, because I work at the M clinic, and all the people there are MSM, and I see a lot of people, they come back for treatment because when they came for their asymptomatic screen, they would have had all the tests done, and they're feeling fine, but it's turned up gonorrhea or chlamydia in their throat, or gonorrhea or chlamydia in their rectum, and they're feeling fine, but if we hadn't have done that, they would never have known, and they probably, may well have passed it on to other people.
Yeah. Okay.
And I guess this is not just for men, but for women too.
Yeah.
And I think if we have those pictures on the toilet doors, to say, well, look, this is what is recommended. If you do this, well, then they can make up their own mind whether they need it or they don't need it. Yeah. We don't actually have to know.
Yeah. I can actually share those the forms that I've found from that are quite good to put on the back of the door. But as Donna said, it's also in the silver book. Is the silver book something you can download that picture? And
I'm pretty sure you can download it. Yeah.
Okay.
Yeah, Matt's online and listening. I'm pretty sure those two pictures are in the silver book, and you can just print them off.
Yeah.
Matt's going to send it to everyone. Wonderful.
Yeah, I'll send it to you afterwards, Veronica, and then you can send those out to everyone, because they are as either printable. The other one is, if you would like a rip-off flyer pack, we've still got some, I think, in our resources that can be ordered off quick mail. So services, if they did want to just sort of rip off a flyer and then hand one to the patient to take to the bathrooms with them, there is, I think, some of those still available as well, but I'll double check that and let you know.
Matt, have they got anal swabs on there too, those tear-off ones?
Yeah, so we've got one that's for the lower vaginal swab, and then we've got one that's for rectal swabs.
Okay.
We don't have any for the, I was unsure if they've made a more updated version for the cervical screening swabs.
Yeah.
I know what the ones that we have, I don't think we've updated since then, so there might be a separate one for that, but I'll check all that.
Okay, great.
And I think that, that idea of just saying, look, we offer the throat and rectal swabs routinely to everyone is a really good way to go. And I've noticed at the M clinic, some of the guys say, well, no one ever goes near my bottom, so I don't need that, doctor. And I say, well, that's fine, and I ask them specifically, are you sure nothing goes near your bottom? Not about fingers or mouth or tongue or everything? And they go, no. So, okay, well, that's fine. You don't need it. But for the most part, people will say, oh yes, I'd better have that.
Yeah.
Alvin.
Alvin, yeah.
Oh yes, no, this is a great discussion. I was like, I'm looking forward to like, I don't know if ACWA has resources to look at promoting just getting these checked up in these sensitive areas. Yeah, and also like if we have a something that's already started, just enable the ability to adapt it to look at targeting our community, like if that's all right.
Yeah, oh, I totally agree, Alvin, but we don't have anything, but I think we need to develop something that is specifically for Aboriginal and Torres Strait Islander clients, I think, but also for health workers and staff that, you know, they are a difficult conversation. How can we normalise that conversation? So I think that that's something, and I would really love you know, for your team at Derval to be involved in that discussion about what's the most appropriate resource that we could develop, because I think and something from us would be good. Yeah. Okay. Was there anything else that you wanted to ask Donna while she's here?
Yes. What's that? Is treatment opportunistic? For example, what's that? Presumptive treatment. Is that something to be considered? For example, in regions where they may not have access to pathology or points of care, those kind of particular things. Is silver bullet advice or actually advice and presumptive, or that you need to test positive and then provide treatment?
So if someone has symptoms, then you would treat presumptively. But as I said before, very few people have symptoms. I don't think I've actually seen anyone with gonorrhea or chlamydia of their throat who has symptoms. I only ever see it like as a positive thing on a swab. Certainly the rectal infections, most of them don't have symptoms, but they are sometimes symptomatic, and people will, you know, they'll say, look, I've got this sticky stuff coming out of my bum. Well, if that's, and usually it's quite uncomfortable for them. So I would offer presumptive treatment after taking the swab. But yeah, it's just kind of not that common.
Yeah.
that people present with symptoms.
From your experience, it is a great idea to have a supply of doxy on standby within your own place.
Yes,
like for example, in Perth region, we've had some supply chain issues.
Yes, I mean, I think all these treatments for STIs, be they the benzathine penicillin or the Zap Pack or Doxy, you know, whatever it is that you know, ceftriaxone, yeah, pretty every clinic needs to have, you know, a good supply of these things, because when someone needs the treatment, they need the treatment. You know, you can't tell them to go away and come back.
Thank you.
Brenda, can I ask you, in the goldfields then, I know that the GPs, you go out and actually deliver treatment to the GPs in the goldfields so that they've got some in their stock. Is that correct? Yeah.
That is correct. Yes, that is correct.
And that includes doxycycline as well?
Because we are in the goldfields and a Zap Pack is one of the treatments that we use. So we tend to find that the GPs will tend to ask for the Zap Packs, but yeah, and more Zap Packs are given. But yes, with the wake of the Doxy being now the first line, I think we will start to look at that. But Esperance tends to go for the Doxy more. So we tend to see more doxy given in Esperance because they're sort of an outbreak region, but they're not, so
Yeah.
they don't have a targeted audience. Yeah. And just a question for Dr. Mak as well. So with the change to doxy, have we seen the compliance? Are we expecting that the compliance rate will also go down because it is a 7-day course and it's quite a, not a very happy drug. So did we factor those in?
Well, I think we really are relying on our doctors and nurses and health workers to make that clinical decision about, which patients should get the doxy and which ones you continue using the ZAP pack with. Certainly I know that for the people I see in the M clinic, like, I don't have any doubt that they will continue to take their medicine for 7 days. But if I had someone who I thought, I'm not really sure, then I would just treat them in the clinic, with a stat dose. I think that's something that practitioners, like, you're all experienced practitioners. You have an idea of who needs what, and we just have to trust that you're getting it right, and that the patients will do the right thing. And if they've got symptoms, they want to get rid of their symptoms. So I think mostly they will. And if someone doesn't have symptoms, but they've been told you've got a positive whatever throat swab or rectal swab, and they've actually done the right thing to come and see you, that says to me they actually want treatment. If they didn't want treatment, you might ring them up and tell them, oh, you need to come in, or they just won't come in. So, I think we can trust people with these sorts of things and use our gut instinct as to whether, which treatment to offer them, which is going to suit them the best.
Thank you for that, Dr. Mak. Thank you.
Yeah, and I think we can, and if you're not sure, you can always ask the patient. You can say, look, this is one option. This is the advantage of this option. This is the disadvantage of it. This is another option. This is the advantages and disadvantages, and see what they say they want. So, give them some choice in it. People generally like that, being given choice.
So can I ask then, what would you say would be the advantage if you were to say that to somebody?
So I guess the conversations I'm having are with MSM in Perth who go to the M clinic. So they're a particular patient population, okay, and that might not apply to everyone. But I talk to them about, something that is less broad spectrum, and so is less likely to facilitate development of antimicrobial resistance in the community. Now, that kind of argument may or may not be relevant to everyone. So if it was someone who I thought, well, that's not something that you're very interested in, or if I start talking about it and their eyes glaze over, then I don't worry about it. I also talk about, especially for MSM, I talk about MGen, that, we need to save up our azithromycin for people who've got Mycoplasma genitalium, because that will become resistant to azithromycin if we splash it all around the community. And again, I choose the person that I have that conversation with, and if they look like they're very bored with me, I stop. But yeah, those are some of the things that that I would do. But I'd be interested to hear from our very experienced practitioners on, in the video conference. What do you do, and how do you make those choices?
It's Jem here from SWAMS. Yeah, very similar to you, Donna. We just assess whether they're likely to be compliant with the treatment, and if there's any reason that we think they won't be, well, then we just give the azithromycin. And then also that option, we just go through it with them as to what they would prefer, or what they would be likely to be able to complete a course of 7 days. The other thing is that with obviously waiting 7 days from the end of treatment to not resume sexual activity. Sometimes if someone needs just a stat single dose, because that's a bit more difficult to wait, potentially 2 weeks.
2 weeks.
Yeah, so that's the other consideration that we also look at.
Yeah, great.
That's a good point. Yeah, thanks, Jen.
Yeah, thank you.
Yeah.
Okay, Sarah said, yep, she does the same, and most people opt to have the stat dose. No, that's fine. Yeah.
Yeah. Yeah, so Sarah's up in Roeburn, so in the Pilbara.
Yeah.
Okay, well, I'm a little bit mindful of the time as it's a bite, which is usually we just do the half hour. Was there any other burning questions from anybody out there in the regions or from the metropolitan area? I guess from me, just one more thing was around the SASA, Donna, and I know that it said in the initial email that was going to be updated, so I'm not sure whether that's happened or not.
Yeah, it hasn't happened yet, but it's certainly in train.
Yeah, okay.
Yeah, so it should come pretty soon. And we're actually updating the STI treatment SASA to also include syphilis, so that, you know, like it's all in one document. You don't have to go to many different documents. Yeah, so that kind of has held it up a bit. But yeah, it's certainly in the pipeline. Hopefully won't have to wait too many more weeks to see that new SASA.
Okay, that's great. All right then. Well, thank you very much, Donna, for delivering the bite today and joining myself and our regional teams out there. Thanks to everyone from both Archers and Department of Health and any other services out there. I'm not quite sure all of you. Thanks for joining us. It is being recorded. I will forward that out to the group if you wanted to share that with any of your colleagues. So thanks very much.
Thank you for the opportunity. And I think it's been such a wonderful discussion, and it sort of took us to somewhere where we weren't, I didn't predict that was where we were going to go, but I actually think that's a really important discussion we've had, because there's no point talking about how to treat rectal and pharyngeal infections if people aren't testing.
Yeah. And also, you know, what resources have we got to be able to, you know, give people those skills and that motivation to actually offer that. So thank you to all those that gave us some insight into that, and I'll be in touch with you, Alvin. Okay.
Right. Thanks very much.
Thanks,
Bye-bye,
everyone. See you.
Thanks, Donna.
Thank you.
See you, Monica.
Bye. See you guys.